Okay, welcome to another episode Women Investing in Women, Women in Tech, AI, Gender Bias. And then today we're specifically talking about healthcare, of course, with my co host, Shay. Hey, Shay.
Hello, thanks for having me for a third time. And this time, the topic, as always, is both interesting and horrifying. And so I'm excited to dive into the facts. I'm sorry, guys, my voice is a little bit gone. I've been sick, but I will try my best to still voice the facts and the opinions.
Yes, yes, yes. And before we start, it was on my mind to just give a little love and a shout out to Ananda Lewis, who just passed away from breast cancer. And Ananda, I feel like I grew up with her. She was the MTV VJ when I was in my MTV watching days as an adolescent. And I think a lot about the how she decided to treat her cancer and some of the flack that she got about it. But frankly, at the end of the day, it's her body and she can choose to do what she wants. And when we honor people, that's what we do. But I think a lot about how many people don't actually want to do mammograms and other invasive procedures. A, because they're nerve wracking, but also because they hurt, they take time, they're uncomfortable. And I think to myself, what can technology do to make these tests that we have to go through, especially when you hit a certain age? I'm at that age now where you start doing your mammograms. I'm gonna be getting to the age where we have to start doing our colonoscopies and taking my friends to go get their colonoscopies, etc. And some of these procedures are just invasive. And like I'm thinking, there's the opportunity, I think, with AI and some of the emerging technologies where some of the stuff doesn't have to be as invasive as it has been. It doesn't have to be as traumatic and trauma inducing as it can be, and anxiety inducing. It's anxiety when you have to go to get screened for something that could potentially take your life in a way that you're not necessarily expecting. So, but anyway, I wanted to it was just on my heart to just give a little love to Ananda, to her family during this really tragic time, but to also think about what are some of the innovative technologies that can make this process, especially for women, which is oftentimes painful processes to go through, a little less painful, a little less anxiety inducing, and a little less traumatic. So I guess we'll talk a little bit about that. So even though the stats are horrifying, hopefully at the end we'll find some hope, some points of hope. And that's the thing that I think I like about the technology, is that as things are being co-created, there is an element of humanity and hopefulness to the work.
Yes. So, first of all, my condolences to the tragic news. So I like to start this with just the main fact that we've been continuously addressing regarding AI, because I feel like I am the responsible one here for that. I am not an expert on healthcare. Just want to state that anything that I will say and I will voice my opinion about is mainly scenarios that I have experienced in my life and with my surrounding, which I think is equally important, because in the end of the day, it is our experiences that are also going to shape the
Yes.
solution that we come up with. And secondly, it's hard to find studies on things, because there has simply not been studies to support certain things. And what I mean by that is, I will come back to that later. However, I just wanted to say that in the AI technology, again, we need to know that the technology itself is inherently not biased.
Mm.
And so, whatever the technology is replicating to us is just what we have normalized in society throughout history, all the data that we are feeding the AI can have assumptions, although we don't directly program it into there. And so let's address the first fact that most medical trials are done on men, and completely women are completely ignored, or there's just a very small percentage of women who are being subject of these trials, which concludes to misdiagnosis. It leads to wrong dosage of medication, no information about side effects. And yeah, I have a really cool example about that, but I really would like to know your view on this.
I mean, yeah, I think we have a plethora of information around different health um, ailments, and most of it is done on men. The interesting part, though, is that there also is a history of doing a lot of terrible experimentation on Black women. So from the moment that we were brought over as slaves, the experimenting that went on our bodies to just sort of understand about, I don't even know what they were necessarily trying to find. I think a lot of it was around reproduction,
Mhm.
in fact, right? And there were covert, even up through the civil rights movement, there were covert policies by governmental agencies to do forced hysterectomies on women who didn't even know that they were getting hysterectomies. So not only is there a lack of knowledge around women's healthcare in general, but then there's this really dark, underseated piece of medical history that also has found its way into AI biases around how Black women can tolerate pain. For example, there's a belief that we have a higher threshold for pain. Well, no, not necessarily. It's just that no one cared that we were in pain because they didn't see us as human beings. So when it says like you don't need anesthesia to go under this particular procedure because you have a high threshold for pain, it's erroneous, right? But they're getting that information because they experimented on Black women without any anesthesia, because they didn't really particularly care. They didn't see us as human beings. So even those kinds of things are also finding their ways into the ways that doctors and healthcare providers interact with women and interact with Black women in particular.
Absolutely. I believe it's so crucial to also highlight that within the intersection of women, there is also minorities such as Black women, which I found out they are 3 to 4 times more likely to die from pregnancy-related issues than, for example, white women. Which again, it could be, or I'm sure it is because of not taking real care about what their symptoms are, not diagnosing or interpreting it in the correct way that is relevant for them to heal, and unfortunately to survive. And I actually have this horrible, horrible personal story. Because for everyone who didn't know, I volunteered for 6 months in the hospital, because back then I was really interested in studying medicine. And so this was also part of um, uh, entering the German medical system.
Mm.
And I was working as a nurse assistant, basically, but because of the lack of nurses and the lack of labor force in the medical field, oftentimes the assistants had to do stuff that we were technically not allowed to practice
Yeah.
as assistants. So basically nurse tasks. And I will always remember it was 6 a.m. in the morning, and I arrived on the station. I was working at the internal station, so anything related to, for example, lungs, gut, stomach, intestines, and so on. And the first thing I hear is a loud scream from this room. And I go there, and the woman, she didn't speak German.
Mm.
She was an immigrant, and I think around her 40s, maybe beginning of 50s. And she said that she couldn't breathe. So she didn't specifically say it, but even I could understand from her gesture
Yeah.
that she couldn't breathe, that she needs help, and she was screaming. basically. And I look around and I see nobody. So at 6 a.m., normally it's the transition of the shifts. And so mostly the nurses are in the nurse room, where, you know, they just report to each other. The night nurse reports what's been going on to the morning nurses. And so I see them sitting there sipping their coffee, and I still hear that woman screaming.
Wow. Wow.
And I'm like, guys, I know I'm new, but shouldn't we, you know, take care of this woman? She seems like she's in pain. And one of the nurses just like really casually said, oh, well, I checked her oxygen levels. She's fine. And she's just being dramatic.
Wow.
And
Wow.
unfortunately, so I sat down because I was super unsure and uncertain on how to react. Again, I was new. It was, I think, my third or second day.
Oh my God.
And so I just sat there to, you know, do the reporting, hearing this woman screaming in the background. And all of a sudden, a doctor rushes into the room and he says, we need a very, very quick, like, CPR, like, we need to revive this woman immediately. And like alarms were like turned on. And I just see everybody rushing to that room. And yeah, well, that woman was dying.
Wow. Wow.
And it was a long, I don't know how you say it in English, emboli,
Oh,
basically
yeah, pulmonary embolism.
embolism, exactly. And I mean, I don't want to be graphic here, but the scene of just like her CPR was horrific. I'm still traumatized to this day. And then she was brought to the emergency, how do you say it, surgery. And so I was just sitting there and I was just like praying, like, oh my God, I hope she's fine. And I was so angry because I thought, why is this woman not being treated when she is expressing pain? Why is it immediately that she's dramatic? Is it just because she's an immigrant? You know, she kind of looked like me. And then I was just sitting there and hoping that she will survive. And unfortunately, in the afternoon, by the end of my shift, they told me that she passed away and that I need to go clean her, you know, bed and her, how do you call it, her closet and everything, because there was a lot of blood there through the CPR. And so me, second or third day, I'm just crying and like cleaning this. And then I had to give her stuff to her daughter, who was also a very young woman. And I just looked in her eyes and I said, I am so sorry. And I didn't know if I should tell her, what should I do? And so with this story, although it's like, I'm so sorry if this is like triggering anybody or it's very graphic, but this story will always remain with me because it's such a good representation of how unfairly minorities are treated, and yeah, how what the consequences of that are. And so I am pretty sure that that case was never legally pursued, although I really hope it was, but I don't believe that it is, because also oftentimes in this type of scenarios, nurses and doctors, they kind of support each other, like not support but like back each other. And so there is no legal issues. And again, I am not a medical expert. I cannot assume if this woman could have been saved or not. But just the reaction to her being in a pain that fills the halls of the hospital with screaming and that not being attended was for me horrifying.
First of all, I just want to acknowledge you being open and transparent with us, and I can feel the trauma, so I can just imagine having been there. And I think you're right. It illustrates a lot around the words that people use, not just around immigrants, but around women in general, when we express a feeling, we're dramatic. That word is it's so dismissive of women's pain. And the fact that she was screaming, and then she was doing the breath thing. And actually, when you were talking about it, I was like, this is a pulmonary embolism. I'm actually quite familiar with them because they are blood clots or something that women are prone to, especially if you take birth control. And a lot of people don't talk about that. And they're like, oh, okay, what's a blood clot? Well, a blood clot can kill you. It can travel from your leg to your lung and kill you very quickly. It's pulmonary embolism. And I know people who have suffered from blood clots, and in fact, Serena Williams also suffered from them after she gave birth, right? And no one was paying attention. She's like, something is wrong. And it wasn't until her white husband advocated on her behalf that they actually found out that she was actually very close to death. I mean, that's insane to me. So if someone like Serena who knows her body as a professional athlete, and who's well known around the world, is not listened to, you can just imagine how your normal average citizen is completely dismissed and unheard. And the part about the CPR is something I hadn't really thought about, but I'm going to bring on a guest who I had earlier who we recorded. And one of the things she did mention was when you're learning and practicing CPR, when you become CPR certified, the dummy is not a woman, it's a man, and the dummy doesn't have breasts. And so she was saying that people have no idea how to do CPR on women. So either they are concerned about having to touch the chest, or then they get like too violent. So you were saying like there was a lot of blood. I'm like, how could there be blood from CPR? That's insane. So that lets you know that they're actually going in and probably really cracking the ribs in order to get the heart started, etc. So anyway, that I had not even thought about that, but like that's true. Or like, your crash test dummies in car accidents are all male; they're not women. And I remember a supermodel back in the '90s. I believe it was Nikki Taylor. She got in this car accident, and the seatbelt actually like messed up her internal organs, right? And like no one knew that could be a thing because they had never practiced on women crash test dummies. And yeah, don't get me wrong, yes, it's important to have your seatbelt on, but you can also be seriously injured by the seatbelt too, depending on the crash that is happening. So you brought up maternal fetal medicine statistics. We've talked about the disparities, especially around Black women. We've talked about it, just mentioned about the CPR. So our guest earlier today mentioned some of these things and around some of the work. So I'd love to see if I can get her recording on. Let's see, y'all. We're doing a tech thing, but I don't know how tech savvy I am. So.
You got this. You got this.
So let me see how this goes. Talking again about gender bias and health disparities. So we have the incredible Maria Meyer with us from the Women's Fund Miami. Thank you so much for taking the time out today to talk to us about what is going on in the health space in Miami, especially as it relates to gender inequities.
Thank you so much for inviting me. I loved your first episodes, and I got so excited when you said I could come. I felt I'm right in there, right at the beginning. I'm very excited. And thank you so much for investing in women and girls across the board throughout your entire life, and especially the focus you're doing here and now in Miami, because we need you.
Oh man, thank you. The work is rewarding, but we know we have to be on the ground. We are really talking about people's lives, people's health outcomes, and the quality of life that they have. And the work that you guys are doing at the Women's Fund is really being so intentional and thoughtful around making sure that we are creating an ecosystem where women are living their best lives, where our young girls are having the best opportunities afforded to them.
And it uplifts everyone.
That's right. That's
There's
right.
No question.
An investment in women, it is an investment in the entire community.
We say that we focus on women and girls, and I'm preparing for my board retreat. So you see, I say, I always have these big gender lenses, and I'm about to use this one for board retreat. We really still need a gender lens on things, not because we don't care about every gender, not because we don't care about other lenses. All lenses are important. You see things differently. And when you identify the issues, then you can look at the data and leverage resources, look to find resources to leverage on behalf, in our case, of women and girls. But it could be of people who speak Haitian Creole. It could be on behalf of people who are living alone and they're women over 90. I mean, who knows, right? It could be different things, but the Women's Fund has identified a lot of things that we need to work on. And one of them is health equity. Yeah. And it's a really critical time, as you and I have discussed offline. So I'm really happy to be here today and say that we do have data. And overall, the United States, it's really quite abysmal where we are for such an amazing country. To be, according to some statistics, we're 69th in the world vis-a-vis, maternal and infant mortality and morbidity. It depends on which way that you look at the statistics, but no matter what, we are not at the top of the pile. And that means there's opportunity and a lot that we can do about it. So we've been privileged to be asked by asking so many questions of others and looking at the data and the stats for maternal and infant mortality and morbidity in Miami-Dade, we saw that there's huge racial disparities and that the numbers themselves are really high. So it's unconscionable that the last time when we started working on this with many other brilliant leaders, we never do anything alone. We were looking at, you were over 3 times more likely to die if you're a Black woman giving birth in Miami-Dade than white. Kwamara, it's gone up to 5 times more.
I mean, when you said that to me, I remember we were like having a conversation over some appetizers, and my jaw just hit the floor. And when I think about the fact that my mother is a retired OBGYN, maternal fetal medicine specialist, perinatologist, one of the few Black women in the world, and her friends were talking about this 30 plus years ago, and we're still having the same conversation. It is, like you said, unconscionable. And I'm hoping that in 30 years, this won't be the conversation anymore. It'll be about how we have amazing outcomes for our women, especially our women who are giving birth. I think that there has not been a lot of attention given to how the body changes. It's a beautiful time, but it's also a traumatic time for the body, that it is actually major surgery. You're going through a major thing, bringing another being into the world. And then what happens afterwards, postpartum, your prepartum bodies, like all of that, what happens psychologically, your hormones. I mean, there's just so much that has not been researched that we don't understand that contributes to a lot of these gender disparities and inequities. And when you said, the 5 times statistic, a friend of mine who's a Black woman recently just gave birth as a woman over 40. And she's obviously thrilled to have her child. But
congratulations.
Yes, thank you to her. And
yes.
And she was basically like, I was in labor for 20 plus hours. I had to have an emergency C-section. I need to talk to your mom. A lot of my friends were like, I need to talk to your mom about like what happened, because she's basking in the beauty of having her child, but it was also a traumatic period of time for her to go through that labor. And so I just thought about like, wow, how timely is it that we're going to be talking about this with someone who's actually going onto the ground. So can you talk a little bit and tell me a little bit more about the stories, the statistics, the stories behind the statistics, and then what exactly is the Women's Fund and the coalition doing to try to sort of eradicate as much of these gender disparities as we possibly can in the maternal mortality and infant mortality rates?
Well, first, let me thank your mother for her work. And I know in a podcast, you always think, well, I'm a huge podcast listener. I'm a super groupie and addict.
I love it.
And I always think I'm going to remember everything, but I don't. So if anybody takes away one thing from our conversation, is that we need more of your mom. One of the things that we know, that the racial disparities that we have, we want to, every single baby and every single mother counts. All of our blood is red. Number one, all we care about quality, we got mortality and morbidity, about health for all of these human beings, right? But when you look at these incredible disparities, it's not only, some of it's economic duress. So there are huge pressures. It makes a big difference if you can afford healthcare. It makes a big difference if you've got a job who's giving you time off to go to your appointments. It gives you a big difference if you're given time to breastfeed, et cetera, et cetera, et cetera, right? But it's not the only reason. Many Black women have had incredible duress, and some of the most privileged athletes and entertainers. So Beyonce had issues, Serena Williams had issues, Christy Turlington and had some issues, even though not necessarily a woman of color. Allison Felix, the Olympiad, had issues, but hers were especially economic.
Yeah.
Because female athletes aren't supposed to get paid or any time off to do the most important job, the most important race you'll ever run, which is giving birth. So a lot of the qualitative information points towards not having people who understand and to listen, right? So more physicians of color, more people who are culturally competent, more people who make people feel competent in defending their own health and explaining their own ways. We know the pink tax of health, and you were just talking about that the other day. You and I were talking about it, and then I heard it on your podcast. I mean, that gets me so going, that the way that men manifest a heart attack is different from a woman. So more women suffer. That Resuscita Annie wasn't designed with breasts, so most people are afraid to do CPR on a woman. Crash test dummies were modeled around men. So we know that there's a health tax, a pink tax of not paying attention. The same thing happens racially. So hypertension, pretension might manifest differently in a Black woman than a white woman or a Latino woman, and it's not it's not that difficult to figure it out and listen if one is listening, ready, and paying attention. So we need your mom to inspire many more physicians in this country, and that will be a start. Also a question for your friend. Was she able to consider having a doula with her? Do you know?
I don't know. That's a really great question. I'm not sure if she had a doula or a midwife or somebody with her at that time. We didn't get into an in-depth conversation.
Well, I bring that up because it's one of the things that, we find that having an advocate is always important, a health advocate, and somebody who really understands birth. I mean, there are death doulas now too. Somebody who really understands how our spirit and our bodies are at the end of life, right? For the beginning of life. Doulas, I had a doula, and thank goodness, because I love my doctor, but she was helping 5 other women at the same time. And she kind of got it wrong. She told my family that they should go get a rest because it wasn't going to be until the next day. And I said, my doula, hold it.
The baby was like, I'm coming.
Something's different here. So that is one of the solutions. If I mix up, the stats and the solutions, we know that there is a huge, amazing desire by the brilliant medical community and birthing community in Miami-Dade County, which is where we focus. And they want to work together. So let me speed right on ahead to consensus and conclusions and what we can do. Because of the statistics that we've seen in Miami-Dade and in the nation, we know that we're in a maternal health crisis and an infant health crisis, and that there's much, much, much that we can do about it. So what do we do? We have been lucky enough to accepting. I'm in awe of the responsibility of being the central plaza for what is now the Alliance for Infant and Maternal Health Miami-Dade, AIM, Alliance Infant Maternal Health. We have Baptist Health System, we have Jackson Health System, we have Southern Birth Justice founder, we have Metro Mommy and the amazing Esther McCant and others who are working.
Doula, all of that. I love it.
Amazing. University of Miami, really involved leaders from FIU. Jesse Trice, Community Health Center is joining us. FemWell with private physicians. Mount Sinai, their leader is so excited. She says, I'm not only going to participate, but I'm going to overachieve because I'm so excited. So all of these leaders have come together, and a lot of other community leaders who will be surrounding them. So the mayors, Blue Ribbon Committee, Health Foundation, the Children's Trust, Healthier Miami-Dade, Overtown Youth Center, the YWCA. Many of my, closest colleagues are also in the waiting to be ready to pull the trigger, the positive trigger.
Yes, yes.
the one that a flower comes out, not a bullet, on the work of this Alliance for Infant Maternal Health. So they've got four very basic prongs of attack. So one, they've agreed to collect data in a dashboard that they're all looking at together on the 3 to 5 data points that they think are most impacting, that they can most impact and influence birth outcomes, right? So they've determined several for maternal health and several for infant health, and those we're all gathering now. We're putting together the operational definitions and the legal agreements, but that will all live on one dashboard. There's not going to be any finger pointing. It's not going to be, oh, it was a small birthing center. Oh, that happened in a big hospital. That was a public hospital. That was a private hospital. No, people want to know exactly what happened to that birthing person and to that infant so they can share the health data.
I love that, because what you're talking about is transparency, right? So we're coming together to collaborate, create a coalition. We all know that this is an issue. We all want to solve for this problem. Yes. We want the best outcomes for young women, for our women, and obviously for our young children. And so to have a transparent dashboard where the data just lives, where people can look, I think is amazing.
And everybody promising to come together with purpose.
Yeah. I love
Every month we're looking at this. Where are we today? What do you know? What do I know? Okay, now with that, how are we going to take that information and influence the protocols that we can share as closely as humanly possible? Obviously, AIM cannot mandate, we're not the American Medical Association, right? We're not government. So the birth centers and the public and the private hospitals will adopt the protocols that they, as an alliance, determine together as closely as possible to start influencing and see how that affects the data. In parallel, they're going to determine the public awareness campaigns that they're going to share same imaging, maybe different languages, maybe in Creole, maybe in English, maybe in Spanish, but the same images and the same messaging about what you need to know and what you can do to have a healthy birth outcome, whether you're a concierge physician patient, or you're going to Jackson, or you're going to a community health hospital. You're equally important. These things we know to be self-evident, that your blood pressure matters, that it matters that you go to pre and post and consistent healthcare appointments, those kinds of things. Yeah. So that's the third prong. And the fourth will be grant making. We'll be looking for grant community partners, especially we'll be doing RFPs for people to cover what these institutions themselves can't cover.
Right.
For example, we've had so many meetings with the Alliance, so it's bubbling up that having blood pressure cuffs for every birthing person when they leave the hospital could be an incredible tool. Yes. And right now, some insurance companies give it to you and some don't. So it could be that we put in an RFP looking for help. At the same time, we'll be looking for donations. Whispering to the American Heart Association, hey, we're hearing a lot about blood pressure cuffs, and we know you know a lot about hearts. Yes. So that kind of thing. It could be transport to and from doctor's appointments, care coordination, that kind of thing.
Yeah.
The Alliance Comara is not going to pick social determinants of health that they can't majorly influence themselves. So I use food insecurity as one of the issues. It may be that they say, we really do think that next year this time they might say, all of a sudden food insecurity is one of the things that's really affecting, but we as an alliance can't. Me in my job where I am, I don't know how much I can do about it. It's not that we're not paying attention to it, it's just not in our circle of influence as much. So it's a 5-year endeavor. We're really, really excited. It's moving, and because I'm talking to you here, it's incredible, these seasoned professionals with all these titles getting moved and really emotional when they're sitting around this round table.
Mm,
They're saying, this is exactly what we need. We need to accelerate. Getting out of our silos is going to be able to get some quantum leaps towards the goals that we all share. And so I can't even believe sometimes I get up in the morning, I go like, how am I so lucky? And we are, I've got amazing colleagues.
Yeah, it's great. And one of the things I keep sussing out based off of what you're talking about is this humanness, the human connection. You guys are coming around the table, you're interacting with each other as human beings, you're feeling the empathy, the joy, the sadness, the urgency in the room. And it's amazing how often I have these kind of like techie based conversations, and yet humanness always comes up. We're talking data, we're talking numbers, but people care about the things that make us human and the things that make us special. And that is the sauce, right? Like, it's the human power that's going to transform this work, that's going to transform these outcomes, so that in 5 years, we have done a lot to hopefully move Miami-Dade out of these abysmal, unconscionable numbers into maybe a model of success that the rest of the country could be looking at.
Well said. That's why we call it Alliance for AIM, Alliance for Infant and Maternal Health, and we put Miami-Dade on the end. So you could snip and sign let's turn it into South Florida. Let's turn it into Florida. Let's turn it into the nation. Hopefully, we care about every single life and every single human, and behind every piece of data is somebody who's breathing.
Is somebody's breathing. I love that. And somebody's heartbeat. Well, Maria, thank you so much for coming on, for telling us about what is going on in Miami-Dade. I am so excited about AIM. I can't wait to hear more about it and looking at that dashboard and meeting the people behind the work. And this is just incredible. We need to ensure that our health outcomes and everyone is just living a joyful and healthy life, and anything that we can do as a people and as a community to support that, I think is amazing. So
stronger together. Appreciate you getting the word out and everything you do.
Awesome. So make sure you follow the Women's Fund Miami. This is amazing Executive Director Maria Meyer and her team. So thank you all so much.
They're the smarty pants. Okay. Have a great rest of your podcast.
Thank you. Bye.
Bye.
Okay, so there we were. And, Maria said some really interesting things, and the connection between the human power, the technology, the data sets, right? The data dashboard, the transparency. When she started talking these large data numbers, I automatically was thinking large language models, right? And that's going to help us with some emerging tech. So we'd love to hear some of your reactions and your thoughts to the conversation that we had with Maria.
Yes, of course. So thank you, Maria, for also giving us your perspective and giving us awareness about this topic. I think something important she said, as you said, is the transparent data, because, of course, if we have the data collected and written somewhere, we are able to use that data to balance out, for example, in the AI data sets that you feed the AI with, and you kind of create a balanced out view from the AI's perspective. This type of data is so important, and yet we don't have it. And so this is something that we addressed like right in the beginning of this live stream, is that there's just not enough, studies supporting it, or there's not been enough clinical trials, or if there have been clinical trials, for example, in the case of Black women during the slavery times, that it's been horribly executed and not with the right motives, or not in a human way, to be quite honest. And so I think this is something so important to capture this data, to be able to then feed this to these AI models, to be able to kind of design them or develop them in a way that the AI model has awareness of what is actually going on. And of course, this type of things, they go undetected even for the AI if we are not able to capture them. And another thing I believe that she said that I really also believe in, and we also addressed this in the last live stream, is just representation. So diverse teams, female leaders, just as she said, as she showed the lenses, like somebody looking through these lenses, and of course all of these lenses matter, but we can only start finding the solutions by asking the right questions, and we are only able to ask the right questions by being exposed or observing a certain situation from a certain perspective. And so something I really, really like to talk about is a very, very recent phenomena, which is the COVID vaccine. So the COVID vaccine, when it was being tested, there was absolutely no testing on how it could influence women's menstrual cycles. And so I'm not sure if you've heard about it, but in my personal case, for example, I had 2 of the COVID vaccines, and I had problems with my menstrual cycle, and I know a lot of people who had the same issue, and that, for example, like, it was not considered at all. And I know that during the COVID time there was this certain rush of like just finding a solution, but again, we're looking at a woman's body. We're hugely influenced by our menstrual cycle and our hormonal cycle. And so when there's being tests made, I believe it's crucial to also look at what the effects are on that. And as a consequence, when women were voicing their concerns about this, they were labeled as anti-vax. So they were like against vaccinations, and that was just not, like, in most cases was not it. They just wanted to have a more informed decision here, and they were immediately dismissed and labeled as anti-vaxxers. And so I think that's also a really good example, and a very recent example, of how we don't have the data, and for some reason we're also not looking to have that data, and that's deeply problematic. And then for people to then address that and say, hey, I'm concerned, I really would like to know what are the consequences of this, to dismiss that and label them as something they're not, is also deeply problematic. So our reaction to then women being frustrated is maybe not right.
Yeah, I mean, I think we see many examples of that. I was not aware that COVID vaccinations were affecting women's menstrual cycles. I have a lot of severe food allergies. So in fact, I spoke with my doctor, and she asked me to wait about 6 months before I would take any vaccines to see were people having adverse reactions, etc. So, but that's because, like, literally, I will say one of the great things about having your mom be a physician is that I have formed really close relationships and friendships with my own doctors, and so just texted and were like, what do you think about what I should, what do you think I should do? Should I take it or not? And she was like, let's just wait, a few months, continue to mask up before you go ahead and do that. But not everyone, of course, has that kind of line of communication or that support system. So yeah, I was not aware of that. But one thing that I do want to talk about, something that's kind of happened in real life. So there's a Reddit community called 2X Chromosomes, which is really a woman-focused community where women go in there and talk about issues that affect women. And one of the issues that kept coming up was the IUD insertion and how painful it is, and how it is not protocol or practice to offer women any kind of pain medication or pain management, no localized anesthesia, nothing. And it became such a hot topic. So many women complaining about it in this community on Reddit, 2X Chromosomes, that now there's actually through some physician policies, now there's becoming a policy, I think specifically in the UK, but hopefully in the United States, where it is now protocol to ask if a woman would like local anesthetic, and she doesn't have to advocate for herself to do it. Why? I mean, to me, it's just ridiculous. Obviously, you're inserting something into a very sensitive area that has a lot of nerves. Of course, it's going to be painful. So the idea that you can't offer a local anesthesia is ludicrous to me. It's
And you know
literally
what's funny? And not to cut you, but I have such a funny example for this. Actually, the male non-hormonal contraceptive injection, because there has been now one that is actually non-hormonal, which is a needle. It's kind of an injection. That one was automatically coming with a local anesthesia. Automatically, no questions asked.
no
No
question.
questions asked.
So this idea
That
that
is,
women withstand physical
yeah.
um, pain more than men, though I thought they were the stronger sex. Anyway, uh, is ludicrous, and you see all of that in the ways that people interact and react to women. So we see it in the workplace when women are frustrated, oh, they're ruled by their emotions, oh, they're cat, I mean, they're all the negative things, oh, she's a bitch, etc., when she's being assertive and having a particular leadership style. But then it really has true outcomes on whether or not someone lives or dies. I just read an article about a woman who was advocating for herself. She was like, I'm in a lot of pain. Something is not right. She wanted to do a cancer screening. She was young. I think she was in her mid-20s. And the doctors were like, no, you're too young to have cancer. Well, anyway, long story short, she passed away from cancer, literally. And she wrote this whole thing about how she was advocating. She knew something was wrong. No one was listening to her. No one was listening to her pain. And so we're talking about this, but this erroneous information that is coming out that then allows people to say, well, the data doesn't show that, or we can't believe your pain because historically we don't have any data that says that women are in pain, and if they are in pain, they're hysterical. I mean, whatever. And then a person loses their lives in probably ways that could have been prevented, or at least could have had a longer life outcome than she ended up having. And so that's why it's so important for us to have these conversations. It's not just that we want to change the AI algorithm, it's because literally people's life expectancy can be altered, right? And people's life outcomes can be altered when we do not have the correct data to allow for diagnosis, to allow for human centered healthcare, especially as it relates to women's healthcare.
Yes. And so I really would like to address also some historical data in this, that not too long time ago, like around the 90s turn, women were sent to psych wards when they expressed unsatisfaction in their marriage that had nothing to do with their health. And also, I know this might be a touchy topic, but just the religious perspective of women having to endure certain pain, and just I don't want to say that specific. I don't want to pinpoint specifically the root cause of this. I just want to show different factors that kind of came into this bigger issue, as we always have to look at things, is that we need to look at the multiple layers, multiple directions, and multiple dimensions in which this problem was formed, and the streams of how this was influenced. And so, for example, women were removed tooths or teeth because they were not sexually pleasing their husbands, for example, or the fact that women are given antidepressants so easily when they express dissatisfaction in their marriages that were absolutely inhumane towards the woman. And obviously, like lobotomies, being sent to psych wards. There's very, very sad stories about how women who, for example, a woman who had a high sex drive, her husband actually went to the doctor, and the cure of that was to sleep on needles or to put certain poison or chemicals on your genitalia. And that is to me, if we look at this, if we look at the history of how women have been treated, or how the medical system kind of came into being, and kind of seeing from what point did we start that we ended up here, I think that might also be really relevant for us to assess this situation and kind of go about the solution, because this has always been like this. And and so I believe having awareness also about the past and what many women had to endure, and there was nobody advocating for them, as Maria said, that kind of shows us what it kind of took for us to be at this point, and why, as you said, we're still having the same conversations after 30 years.
Yeah, I mean, that history and that trauma, and by the way, and we're bringing this up so you can understand the layers, but also that information becomes data that then feeds the algorithm and feeds these large language models. And as we were saying, like, this data is not, it's not truthful, it's not accurate. And so when you were saying about the power that the husbands could have over their wives historically, and even to degree sometimes even now in a medical setting, so in that same Reddit community, often hearing women who are frustrated, who are trying to get hysterectomy, and there's different types of hysterectomies, by the way. If you didn't know that, you can go and research. I just found that out myself reading 2X chromosomes. And so and women who are like, they want to get a hysterectomy, and the doctor will be like, well, what does your husband want? And she's like, it don't matter what he wants. It's my body, or I don't have a husband. And then they're like, well, okay, well, maybe one day you'll get married and have children. Maybe one day I will get married. Maybe I won't. But one thing I do know is I don't want no kids. So can I have this hysterectomy? Right. Yeah. So like even the fact that women's healthcare is being opposed to, well, what does the man in your life want, or the fictional man who does not exist, what would he want in the future? It doesn't actually matter, and these are conversations that are still happening in the year 2025. That's the disparity. I can't imagine that a man goes and says, hey, I need XYZ procedure, and the first thing the doctor says, well, what does your wife think? It would never be the case. It would be like, okay, let's talk about what your options are. Why do you want to go this way? And they would have a conversation and come to a conclusion. Those kinds of things oftentimes do not happen in a setting when a woman is trying to advocate for her health care. And so what are we going to do about it? I think this is really the point. I think we're going to have conversations like this. We're going to have communities that are women-led, that are then people are sort of uncovering, well, actually, this is a real issue. Now let's try to solve for it. And most likely the people who are going to try to solve for them are going to be women, are going to be folks who are diverse, who have seen this play out on the ground in some way, shape, or form. And so that's the importance of the diverse funding. That's the importance of women being in tech. It's the importance of us participating in the algorithm just as normal citizens, so that we can start changing what that data is saying, and we have more trustworthy, factual data that really illustrates true outcomes.
Yes, 100%. I would like to just, for our final outcome or our final sentence, also bring light to something that personally affected my family. So my mother was diagnosed with an autoimmune disease just like 2 years ago almost. And it's been such a difficult journey for her. And there's just so many layers of like getting appointments, finding specialists, finding someone who takes your symptoms seriously. And it took her actually over a year to get a diagnosis for that autoimmune disease. And I also want to shine light to the fact that 80% of autoimmune diseases are women. Women have 80% of autoimmune diseases. And I believe as the nature of autoimmune diseases is something suppressed in your body, it can also be genetic caused. But from my perspective and the way I understood it, and I actually listened to a lot of podcasts also to understand what my mother was going through, and that there's just so many things that influence a woman's body. And so for women's health, we have to have a holistic a view of the woman's health. So even in like oncology, like cancer diagnosis and everything, you don't only look at the physiological factors, but you also look at the psychological factors. You actually have to understand the history of what the woman went through. And is there enough capacity for us to cover these appointments in a timely manner? Is there enough tests on what these actually mean for women? Are we looking at women's health in a holistic way, or are we kind of just, you know, putting a bandage on the issue, just hoping it won't appear anymore, just like to make the symptoms disappear? And I just wanted to really, for our last part of this live stream, talk about this, especially also to kind of talk about my personal experience, and also to thank my mother for being such a strong woman. And her experience taught me that this is the type of issues that we really need to look at as a society. And so thank you so much, Pamara, for shining light on these issues, to giving us a platform to be able to voice this, and also giving us the opportunity to give our stories and our opinions on this. Again, we need facts, but we also need experiences and looking through lenses, and then maybe we can make sense of that.
Yeah, you make a great point. Quantitative data is important, but so is qualitative, and that's the humanness, it's the story behind the numbers. And so I thank you for telling us these stories that have been so personal to you. I also want to thank your mom, because if she's anything like you, she must be absolutely amazing. Hi, Mom. I really enjoyed getting to know your daughter. She's absolutely fabulous.
She's watching, 100%. She's watching.
But yeah, I wish we had more time. This is not the end of this conversation. I think like this is just the beginning. We would love to hear from you all. So please feel free to put your stories, your comments, your thoughts, your opinions into the comments on LinkedIn or on YouTube. I don't know when we'll touch upon this again, but I think it'll always be interwoven into the fabric of what we are doing. But hopefully this at least sets the stage for a conversation that can get more in depth and come up with some real resolutions and solutions for us. So thank you again, Shay. I really appreciate it. We will be back next week for our last installment about women in tech, AI, and gender bias. Peace, everyone.
Peace, everybody. Bye.